Okay, so you want to own a hospital. You picture buying the building, hiring the doctors, watching the patients come in, charging them for the care, collecting the money, and keeping the difference. It sounds simple, but it is almost never simple. A hospital looks like a place that heals people from the inside, but in reality, it is something else entirely. It is one of the most expensive machines a human being can own, and it is a machine that runs every hour of every day. Whether or not a single patient walks through the door, the lights stay on, the machines stay warm, and the staff stay on the clock. None of that depends on whether anyone gets sick this week. To understand what you are actually buying when you enter this world, you first need to understand what a hospital actually sells. Most people think a hospital sells medicine, but it does not. A pharmacy sells medicine. A hospital sells something closer to access. It sells access to a building, to equipment, and to trained people. All of it ready and waiting the moment something goes wrong in your body. What a hospital actually has on its shelves is emergency care, surgery, diagnostic scans, beds, intensive care units, the precious time of doctors and nurses, and the use of machines that cost more than most houses. None of these are products you can stack in a warehouse to sell later. They are services, and a service can only be sold the instant someone needs it. This single fact explains almost everything strange about hospital economics. A factory that makes shoes can slow down its production in a quiet month, but a hospital cannot slow down. The operating room has to be ready at 3 in the morning for an emergency that might never come. That readiness is not free. You are paying for it whether it gets used or not. The basic equation of the business is brutally simple to write down and brutally hard to control. Your revenue equals the number of patients multiplied by the average amount each one generates. And that is the whole formula. The problem is that you control almost nothing on either side of it. You do not decide how many people get sick this month, and you do not decide what insurance companies are willing to pay you for treating them. You just have to be ready every single day for whatever number of people show up. So before a single patient is treated, the spending has already started. Let us look at what it actually costs to open the doors of a hospital. Say you want to build a hospital from the ground up rather than buy an existing one. The first number you will hear is the cost per bed. And the industry's own rule of thumb is about $1 million per bed. That is not $1 million for the whole building. That is $1 million per individual bed. A modest community hospital with around 120 beds, which is roughly 300,000 square feet of building, lands at something like $112 million just for construction. If you try to build a smaller facility, say with maybe 60 beds, the construction runs above $50 million. And if you push toward a large hospital with 500 beds, full trauma capability, and teaching functions, the bill climbs past $600 million, sometimes close to $1 billion. And remember, that massive number is just the shell of the building. It represents the walls, the wiring, the plumbing, and the physical operating rooms. It does not include the machines that actually make the hospital useful. Take one piece of equipment as an example, the magnetic resonance imaging scanner, the machine most people call an MRI. A basic model starts around $100,000. A standard mid-range scanner, the kind a typical hospital actually needs to function, runs between $1 million and $3 million. The most advanced research-grade systems can cross $3 million on the machine alone before you have paid for the room it sits inside. Here is the part nobody mentions when they quote you the machine's price. The MRI has to sit inside a magnetically shielded room built specifically to contain its field and keep outside interference out. Site preparation alone, including the magnetic shielding, the reinforced flooring, and the cooling systems, can run another $300,000. And in more complex builds, that figure has reached $1.6 million. Add it all up, and a single MRI suite fully installed and ready to scan a patient can cost between $3 million and $5 million. That is just one machine in one room. Now multiply that by every department a real hospital needs to operate. A computed tomography scanner, an operating suite, a cardiac catheterization lab, and a neonatal intensive care unit with its own specialized equipment each carry their own seven-figure price tag before they have treated a single person. So already, before you have hired a single nurse or treated a single patient, you are looking at construction costs running into the tens or hundreds of millions of dollars, plus equipment costs that add tens of millions more on top. And this is just to open the doors. The real costs are still coming. Here's where it gets interesting. You cannot simply build a building and start admitting patients. A hospital is one of the most regulated structures a private citizen can own, and the regulatory process alone can take years and cost millions of dollars before a single bed is occupied. In many states, you first need something called a certificate of need. This is a government approval process that asks a basic question. Does this community actually need another hospital? If regulators decide the answer is no, your $100 million building plan simply does not happen, no matter how much money you have. This single requirement has killed entire hospital projects after years of planning. Then comes the accreditation. Independent bodies have to inspect and certify that your facility meets safety and quality standards before insurance companies and government health programs will pay you a single dollar for treating a patient. That process alone can take well over a year, during which your building sits there fully constructed, generating zero revenue while still costing money to maintain. And then there is the most expensive hidden cost of all, which is malpractice insurance. A hospital is one giant liability waiting to happen, and insurers price it that way. Depending on the state and the services offered, malpractice and liability coverage for a hospital can run into the millions of dollars every single year before a single claim is ever paid out. Skip this coverage, and one lawsuit can end the entire operation. Add up the licensing delays, the accreditation process, the legal costs, the insurance, and the months or years of carrying a fully built but non-operational building, and many hospital projects spend an additional 10 to 20% of their total construction cost just getting to the door that says open for business. That is the cost of just existing. Now you are open, patients are walking in, and this is where the real bleeding begins, because a hospital's biggest expense has nothing to do with treating anyone. It is the cost of simply staying staffed and stocked, whether or not anyone needs care that day. First, there is labor. This is by a wide margin the single largest expense any hospital carries, typically eating up around 60% of total operating costs. Your doctors, nurses, pharmacists, technicians, security, cleaning staff, and billing departments. Every one of them needs to be paid every single pay period, regardless of how many patients showed up. And labor costs have not been standing still. Registered nurse salaries alone have risen roughly 27% faster than general inflation over just the past 4 years, as hospitals compete for a workforce that is in many regions simply not large enough to meet demand. Second, there are supplies and drugs. Medicine, surgical instruments, bandages, disposable equipment used once and thrown away, and oxygen. These costs do not sit still either. Pharmaceutical expenses for hospitals have been climbing at roughly 9 to 12% a year recently, and general supply costs have been rising at a similar pace. Third, there is the building itself. Electricity to run machines that need to be on around the clock, climate control precise enough to keep an operating room sterile, and maintenance on equipment that costs millions of dollars and cannot be allowed to fail mid-procedure. And fourth, there is insurance and compliance. The malpractice premiums we already mentioned, plus the army of administrative staff needed just to navigate billing codes, government regulations, and insurance company paperwork. Stack all of this together, and a single hospital of modest size can be spending tens of millions of dollars a year just to keep its lights on, its staff paid, and its shelves stocked before a single payment from an insurance company has landed in its account. The bill arrives every single month, but the revenue does not always arrive on schedule. But here is the problem. There is a trap hiding inside this entire cost structure, and it is one that has destroyed more hospital operators than almost anything else in the business. Every few years, a hospital goes up for sale at what looks like an incredible discount. A struggling rural facility, Maybe a hospital that cost 40 or $50 million to build sells for a fraction of that because the previous owner could not make the numbers work. It sounds like the deal of the century, but here is why these discounted hospitals are so cheap in the first place. Rural hospitals, on average, run on far thinner margins than urban ones, and a striking number operate at an outright loss. Recent industry data shows that nearly half of all rural hospitals in the country are losing money in any given year, and several hundred are considered at meaningful risk of closing entirely. The reason is almost always the same. There are not enough patients walking through the door to cover the fixed cost of staying open and staffed around the clock. So you buy the discounted hospital. The building is real. The equipment mostly still works. But the thing you actually bought was not a profitable business. It was a fixed cost structure attached to a patient volume that was never large enough to support it. And here's the math that breaks people. A hospital's costs do not shrink just because fewer patients show up. You still need a minimum staff on every shift, 24 hours a day, regardless of whether the emergency room sees 3 patients or 30. You still need the building heated, the equipment maintained, and the malpractice insurance paid in full. Your occupancy can drop by a third, and your costs barely move. This is why, since the year 2010, more than 180 rural hospitals across the country have either closed completely or stopped providing inpatient care altogether. They did not close because the building stopped working. They closed because the volume of paying patients fell below the level needed to cover costs that simply do not bend. The cheap hospital was never a bargain. It was a bet that you could fix the volume problem that bankrupted the last owner, and most buyers who take that bet lose it. Now let us talk about where the money is actually supposed to come from, because the mechanism is genuinely clever, even if it is fragile. A hospital does not charge every patient the same way, and it does not make money the same way on every patient. The core mechanism that keeps most hospitals alive is something close to internal subsidy. Profitable departments quietly fund unprofitable ones. Here is how it actually plays out. Emergency departments almost everywhere lose money. By law in the United States, an emergency room cannot turn away a patient based on their ability to pay, which means hospitals routinely treat people who never pay the bill in full or at all. That is simply a guaranteed cost center. Elective surgeries are the opposite. A scheduled hip replacement, a cardiac procedure, or an orthopedic operation. These are typically reimbursed at rates well above their actual cost to perform, especially when the patient has private insurance. One profitable scheduled surgery can generate enough margin to cover the unreimbursed cost of dozens of emergency room visits. This is the actual day-to-day engine of hospital finance. Diagnostics, scans, blood tests, and lab work also tend to run profitable, especially when the equipment is already paid off and simply needs to keep running. Specialty departments like cardiology and oncology often carry strong margins too, because the procedures are complex, billable at high rates, and require expertise that justifies premium pricing. Now do the math the way a hospital administrator actually has to do it. Take a mid-sized hospital generating, say, $600 million in total revenue in a year. Subtract labor costs at roughly 60% of operating expenses. Subtract supplies and drugs, which is another meaningful chunk. Subtract the fixed costs of the building, the insurance, and the compliance staff. What is left in a genuinely good year might land somewhere around 4 to 7% of total revenue as an operating margin. On $600 million in revenue, that is something like $24 million to $42 million in actual profit for the year. That sounds workable, and it even sounds pretty good, but then comes the part that makes this entire business so much more dangerous than it looks on paper. Here is the catch. Every number in that revenue calculation depends on something the hospital itself does not control, which is what is called the payer mix. The payer mix means who is actually paying the bill and how much they're willing to pay. A patient with private insurance might generate strong reimbursement for a procedure. The exact same procedure performed on a patient covered by a government program like Medicaid might reimburse at a fraction of that amount, sometimes barely covering the cost of providing the care at all. A patient with no insurance at all might generate almost nothing, turning into what the industry calls bad debt or charity care. This is not a small variable. It is the single biggest swing factor in whether a hospital turns a profit or posts a loss in any given year. National data shows hospital bad debt and charity care rising by double-digit percentages year over year recently, even as overall revenue grew. And the national picture of hospital margins makes the volatility obvious. Across the country, the median operating margin for hospitals has bounced between roughly 0.5% and just under 5% over the past few years, while a meaningful share of all hospitals measured individually are running negative margins in any given year. If you strip out the largest, best-positioned hospitals, the median hospital in America is sitting closer to break even than most people would ever guess for an industry that seems from the outside impossibly profitable. And this is where most people make their mistake. When they imagine owning a hospital, they picture the institution as a money machine because the bills patients receive are enormous. They forget that an enormous bill and an enormous payment are two completely different things. A $50,000 charge on a hospital bill might result in an insurance company paying $12,000, a government program paying $8,000, or a patient simply never paying at all. The cost side of the business is rigid, but the revenue side is not. And that asymmetry is the single most important fact about owning a hospital. Now let us see what happens when that asymmetry actually breaks a real operator. Meet a cardiac surgeon, the son of Cuban immigrants, who trained at Harvard and the Massachusetts Institute of Technology before becoming the head of a hospital chain that at its peak treated more than 2 million patients across 31 hospitals in 8 states. His name was Ralph Della Torre, and the company he ran was called Steward Healthcare. The story starts in the year 2010, when a private equity firm called Cerberus Capital Management bought 6 struggling Catholic community hospitals out of the Boston Archdiocese for nearly $900 million. Della Torre took over as chief executive, and the company began an aggressive buying spree, acquiring hospitals across the country until it reached its peak size of 36 hospitals, making it briefly the largest for-profit hospital operator in the entire United States. Here is the move that on paper looked brilliant. In 2016, Steward sold the real estate underneath its own hospitals, the actual land and buildings, to a real estate investment company called Medical Properties Trust. Then it leased that same real estate back at a high annual cost. This generated a massive upfront cash payment, much of which flowed out to investors and executives as dividends. Cerberus alone reportedly walked away from its ownership stake with a gain of around $800 million when it exited in 2020. But how does a man who built and ran one of the largest hospital systems in the country end up bankrupting that same system just a few years later? The answer is not that he did not understand hospitals. The answer is structural, and it is the same lesson hiding in everything we have already covered. The sale-leaseback deal had locked Steward into more than $6.6 billion in long-term lease payments it now owed for buildings it used to own outright. Every single month, rent had to be paid on top of payroll, supplies, insurance, and every other fixed cost we have already walked through. The company had converted itself from an owner of hospitals into a tenant of hospitals, with rent obligations that did not care whether patient volume was strong or weak that month. As the rent payments mounted, the cash to run the actual hospitals began drying up. Vendors stopped getting paid, and when vendors do not get paid, they stop delivering. Investigations later documented more than 650 instances of deficient patient care across nearly 3 dozen Steward hospitals. And these instances were tied directly to missing equipment, understaffing, and unpaid suppliers. One case became a symbol of the entire collapse. A new mother died from internal bleeding after giving birth at a Steward hospital in Boston. She died after a vendor had repossessed the specific medical equipment doctors needed to stop that kind of bleeding. And the vendor took it because the hospital's bill for that equipment had gone unpaid. The hospital had the building, and it had the staff, but it did not have the supplies because the supplies had been taken back over an unpaid invoice. By May of 2024, Steward filed for bankruptcy, carrying more than $9 billion in total liabilities. This included close to $1 billion in unpaid bills to vendors and roughly $6.6 billion in long-term lease obligations. In the year leading up to that bankruptcy filing, while nurses reported missing basic medical supplies, the chief executive drew a salary north of $4 million and owned 2 private yachts, one of them valued at around $30 million. Keep this in mind if you ever find yourself looking at a hospital chain's balance sheet and wondering whether the fixed costs are sustainable. 5 Steward hospitals have permanently closed since the bankruptcy. One of them, a 77-bed hospital in a rural Massachusetts town, had served a population of around 115,000 people and handled roughly 16,000 emergency room visits a year. After it closed, ambulance transport times in the surrounding area jumped by about 20% because patients now had to be driven significantly farther to reach the next open emergency room. The building didn't disappear, but the community's access to care did. This is the structural lesson underneath the entire Steward story. The collapse wasn't really about one executive's yachts, even though the yachts made for an easy headline. It was about a financial structure with heavy fixed lease obligations stacked on top of already thin and unpredictable hospital margins, which left zero room for error. The moment patient volume or payer mix shifted even slightly in the wrong direction, the same trap that catches a small rural hospital buyer caught one of the largest hospital systems in the country. Size did not protect it. It just made the collapse bigger. So let us lay out what actually happens if you decide to own a hospital, using the real numbers we have walked through. In the optimistic scenario, you are running a well-positioned hospital in a growing urban area with a strong mix of privately insured patients, a busy elective surgery schedule, and modern, mostly paid-off equipment. Industry-wide, the best-performing hospitals have posted operating margins in the range of 7 to 8% in strong recent years. On a hospital generating, say, $400 million in annual revenue, that is roughly $28 million to $32 million in profit for the year. Your costs are covered, expansion is possible, and the business genuinely works the way people assume it does from the outside. But now look at the realistic scenario, where 2 things shift that are entirely outside your control. First, your payer mix worsens. More of your patients arrive on government programs that reimburse below cost, or they arrive with no insurance at all, which has been the actual national trend as bad debt and charity care have been rising by double digits in recent years. Second, your labor and supply costs keep climbing faster than your reimbursements, exactly as nursing wages and drug costs have been doing across the entire industry. Under those conditions, that same $400 million hospital can easily land at a 1 or 2% margin, or it can slip into an outright loss. This is the exact position that roughly a third to nearly half of all rural hospitals find themselves in during any given year. The difference between the good year and the bad year on a hospital that size is not a small adjustment. It is the difference between $30 million in profit and a multi-million-dollar loss on the exact same building with the exact same staff treating roughly the exact same number of patients. A hospital is not really a business in the way a restaurant or a retail store is a business. It is a fixed, enormous, immovable cost structure sitting permanently exposed to a revenue stream that nobody who owns it actually controls. You do not set the prices insurance companies will pay. You do not choose how many of your patients show up uninsured, and you do not decide whether the next wave of patients needs expensive elective surgery or unprofitable emergency care. What you do control is whether you understand going in that the building is never really the asset. The patients walking through the door and who is actually paying for them is the real asset. And that asset can change beneath you faster than any building ever will. If you found this video valuable, leave a like, subscribe, and comment below which business you want me to cover next.